Hi everyone, my name is Yunhe Li, and my research presentation is called Automatic Segmentation of Lymphoma in FDG PET-CT Images using Convolutional Neural Networks. I would like to thank my supervisor, Jake Kendrick, for providing me with this research opportunity and for being such great support during the semester. Lymphoma is a type of blood cancer that originates in the human lymphatic system. Diffuse large B-cell lymphoma is the most common type of aggressive non-Hodgkin lymphoma, which accounts for nearly 30% of all cases. This type of lymphoma has rapid and uncontrollable growth of B cells. It is notable for its fast progression and potential to infiltrate various extranodal organs. The Australian Institute of Health and Welfare estimates that about 2,000 Australians will be diagnosed with this type of lymphoma each year. The standard treatment for this type of lymphoma often include immunochemotherapy, which can achieve remission in a significant number of cases. However, relapsed or refractory of this type of lymphoma remains a challenge. Chimeric antigen receptor T-cell therapy is a groundbreaking treatment for relapsed and refractory diffuse large B-cell lymphoma. This immunotherapy involves genetically modify a patient T-cell to express a receptor specific to CD19, which is a protein found on the surface of B cells. Once these modified T cells are reintroduced into the patient body, they can effectively target and eliminate lymphoma cells. Clinical studies have shown significant remission rates with this CAR T cell therapy, achieving long-term efficacy in many cases. However, this treatment is also associated with substantial risks, such as cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome. Predictive models utilizing FDG PET-CT scans have been developed to assess the efficacy and potential toxicity of CAR T-cell therapy. This model helps optimize patient outcomes and management associated risks. FDG PET-CT is a critical imaging technique used in the diagnosis and staging and treatment assessment of diffuse large B-cell lymphoma. This method combines metabolic and anatomical imaging, which allows for precise visualization of lymphoma lesions. Fluorodeoxyglucose is a radioactive glucose analog, and it is accumulated in the cancer cells, making them visible on PET scans. When combined with CT, this technique provides detailed information about the size, location, and metabolic activity of tumors. FDG PET-CT is particularly valuable in evaluating the response to therapies like CAR T-cell therapy. It helps predict patient outcomes and potential toxicity by measuring metabolic parameters. This research project aims to develop and validate optimized deep learning-based models for the automatic segmentation of lymphoma from FDG PET-CT images. This project will use two state-of-the-art models, UNet and Swing UNet transformer, to enhance the accuracy and efficiency of lymphoma segmentation. Both models will be trained on the Cancer Imaging Archive open source dataset. This model aims to generate automatic segmentation of lymphoma, validating against manual segmentation by clinicians. By comparing AI-driven metabolic parameters with traditional prognostic factors, the study seeks to evaluate the model ability to predict progression-free survival, overall survival and severity of cytokine release syndrome. The goal is to integrate those AI tools into the clinical workflow to improve the position and efficiency of lymphoma treatment planning and outcome prediction, and also enable personalized treatment approach for patients undergo CAR T-cell therapy. The open source dataset from the Cancer Imaging Archive will be used for training both models. This dataset includes 501 whole body FDG PET-CT images of patients with malignant lymphoma, and 513 dataset without positive malignant lesions, which serve as negative controls. The manually annotated tumor lesions will be constitute the ground truth for model training. The Fiona Stanley Hospital dataset comprised FDG PET-CT scans from a cohort of 40 patients undergo CAR T-cell therapy for aggressive lymphoma. This local dataset includes comprehensive manual segmentations performed by clinicians, which serve as the benchmark for validating AI-generated segmentations. This dataset will be used to evaluate the model's performance in predicting progression-free survival or overall survival and the severity of the cytokine release syndrome, thus testing the real-world clinical utility of the developed AI models. A high-performance workstation with dual RTX 4090 GPU will be used for both model training. This setup can handle the intensive training requirement of the deep learning models. Preliminary experiment to determine optimal hyperparameters will be conducted on the local workstation from the medical physics research group at Sir Charles Gardner Hospital. The NNUNet architecture is a self-configuring deep learning-based method. It is designed for biomedical imaging segmentation. It automates the configuration process for any new dataset, which include pre-processing, network architecture, training, and post-processing. This architecture follows a UNet-like template using a encoder-decoder structure with skip connections. The key innovation of the NNUNet is the systematic approach to configuration. It combines the fixed parameters, rule-based parameters, and empirically learned parameters. This approach enables NNUNet to optimize itself for diverse biomedical imaging tasks and ensuring robust performance without the need for manual tuning. SwingUNet transformer is another novel technique designed for semantic segmentation of medical imaging. It combines a swing transformer encoder with a U-shaped network structure, utilizing a CNN-based decoder connect via skip connections. The swing transformer encoder extracts multi-scale features through a hierarchy structure, which shift window self-attention mechanisms. This enable effective modeling of long-range dependencies and contextual information, which is critical for accurate segmentation. The training data will consist of total 1,014 FDG PET-CT scan images from the open source dataset. The model will undergo 5-fold cross-validation, which involve partitioning the dataset into 5 subsets. In each fold, 4 subsets will be used for training and 1 subset for validation. which ensures that every data point is used for both training and validation across different iterations. This technique helps improve the model generalizability and robustness. To enhance model training, data augmentation technique will be applied. The performance matrix, such as the depth similarity coefficient, position, and the sensitivity, will be used to assess the model accuracy in segmenting lymphoma lesions. The testing will involve comparing the AI-generated segmentations against manual segmentation performed by the clinicians on the Fiona Stanley Hospital dataset. The model's ability to predict progression-free survival, overall survival, and cytokine release syndrome will be evaluated by comparing the AI-derived metabolic parameters with the traditional prognostic factors. This comprehensive approach ensures the model are rigorously tested and validated for clinical utility in real-world settings. Developing deep learning models for automatic segmentation have several challenges. First, the computational intensity required for training deep learning models demands access to high-performance GPU workstations. This is solved by using our local workstation, which has very powerful GPU with RTX 4090. Second, the quality and quantity of the ground truth label data are critical for effective model training. High-quality manual segmentations are essential to provide a reliable foundation for training. To overcome the limitation of dataset size, and the data augmentation techniques will be employed to artificially increase the data size and the diversity, which enhance the model ability to generalize. Additionally, the fivefold cross-validation ensures the model's generalizability and robustness. This research project requires accessing patients' data from Fiona Stanley Hospital on a retrospective cohort of aggressive lymphoma patients who undergo CAR T-cell therapy. ASIC approval from Fiona Stanley Hospital ASIC committees will be sought to gain access to this data. This slide is my study plan. I'm going to start by downloading the open source dataset. In the meantime, I'm going to wait for the ASIC approval from Fiona Stanley Hospital. After investigating those datasets, I will train both deep learning models, followed by a performance analysis of both models. After this, I will do the predictive analysis of the progression-free survival, overall survival, and toxicity of patients. Finally, this brings me to the thesis writing and the final presentation. This page is my reference. Okay, any questions?
Great, thanks, Junhee. See if we have any questions. Okay, Mubasha, go for it.
Hi, thanks for a good presentation. That's good, interesting topic. I have 3 questions technically. So why you selected NNUNet and Swin Transformer for the segmentation tasks? Like why you have shortlisted these 2 only?
The NNUNet I selected because it's a very easy deep learning model you can use because it is self-configuring properties. So it's basically you can use any data set, just put you can see from this diagram, you can just put the data set with this model, it automatically extracts the parameters based on the data set. It's called the rule-based parameters. It's dependent on the characteristic factor properties of the data set you're using. So it's really easy for me to start this deep learning model training, because all the parameters, they already have the fixed parameters and the empirical parameters from this model. All you need to do is send this model your data, and it will automatically generate the rule-based parameters. Another model is the Swing U-Net transformer. This model, because it's a more advanced model. It has it's in addition to the U-Net structure, the convolution neural network, it also have this transformer encoder, which have the self-attention mechanism. It's similarly similar to the ChatGPT we use every day. It can pick up informations which we call them contextual information, and it's very important for segmenting the whole body PET CT images.
So, like, again, the question remains the same, that actually U-Net is easy to use. Swing transformer, you are saying that it is good. But what is the state of the art architecture on the data set which you are using?
I think the U-Net is already the state of the art architecture. And
on the data set which you are going to use, yeah, you have a training data set.
Yeah, I have a training data set. Is from
which
the open
model is the state of the art on that training data set?
I think the U-Net is the state of the art one. The Swing U-Net transformer is like an experimental one to test the model performance. Yeah.
Okay, I think you need to read about them and get more thorough knowledge that actually what is the difference between these different architectures. And obviously, if you are trying it yourself, something, you need to first learn from the literature that actually state of the art work is already there. So what is the best model which is actually there? Yes, you can take the top two, but the point is that what is the use for that? Because you are actually trying to do is that one is the NN U-Net is basically CNN approach, which you are taking there, and then you have a transformer U-Net model. So you are trying to compare both of them, which is technically will become a redundant task because it is already there in the literature. So you can take the best one and actually apply it on Fiona Stanley dataset rather than actually going through it, because NN U-Net is also very slow, remember, because it will take long time to train it. Second, another question is that you mentioned that actually you are going to go ahead with the first initial training of the transformer. Are you planning to do fine tuning, or you are just training it from scratch?
Currently, I'm still learning about the deep learning things.
Okay.
So I think I will be training from scratch, try to do that.
That's not a good idea, especially for the transformers, because normally transformers are trained on a very, very large data set, and 1000 data set is very small, and especially when you are doing 5-fold cross-validation, it is left with about 200 cases only. So I will suggest that if you go ahead with the fine-tuning of the Swing transformer or whatever the state of the art, first find what is the state of the art on the data set which you are going to use, which is open data set, and then actually go ahead and actually. So if it is already trained, technically you don't need to train on your same data set unless until you are selecting some different network. Yeah. Okay, all the best. Interesting project.
Thanks, Mubasher. Martin, do you have a question?
Yeah, that's great. Thanks. It's been great to see the collaboration with Fiona Stanley. That's really, really good. So the TCAA data set, I'm assuming you've already looked into it, and there are no approvals required to access that data set.
Yeah, it's an open source data set.
Brilliant, excellent. Another thing to note is that we're actually involved in a couple of trials, national trials in lymphoma with PET imaging, and I think one of them has acquired about 30 patients so far, and the other one's just started. But so it won't be ready for your project, but your project will be really helpful when it comes to analysing those data. So I'm going to ask, were you going to look at the normal tissues at all, the normal organs? Just because I imagine from T cell therapy, you might get inflammation in organs, and FDG will get taken up where there's inflammation. So I wonder if you're going to look at maybe using something like total segmentator to delineate individual organs and look at how they change as well, what the signal is in those organs.
Yeah, I will definitely try the total segmentator.
Yeah, I think that shouldn't be too hard to do. We're also, our collaborators in Wisconsin have previously developed a model for FDG lymphoma. We can probably get hold of their model if you wanted to compare it with the one that you develop on the TCIA data set. That might add an extra nice dimension to your project. Or you could also, I don't, I'm not a deep learning expert, but I imagine there's a way of transfer learning from their model that might help to make your model more accurate.
Yeah.
Yeah, those are all really great points. Thanks, Martin. I really like the idea of using total segmentator to look at some normal organs. Like one of the main things is neurotoxicity. So there's potential to look at both the PET and the CT scans in that capacity to see if we can predict those catastrophic neurotoxicities. Nathaniel, did you want to jump in?
Yeah, thanks, Ewan. Yeah, great presentation. I just wanted to have a quick question about what is your plan to implement and train first the NNUNet and also second the SWIN transformer architecture. So basically, where do you find these architectures and how do you basically train them? So what software may you need to use to train some of these?
First question, these two architecture is recommended by my supervisor, Jake. And I will train them using Python. I already have some experience with scikit-learn. So I will do the training with the Python code. Yeah.
Okay, so would you require because I'm not too familiar with the SWIN transformer, but I'm guessing to implement the architecture, you may need to use something like Keras or PyTorch or something like that.
Yeah. Currently, I only have some experience with simple machine learning models. So I would continue to learn how to do that for the deep learning one after the final exam. Yeah.
Would you be able to go to your study plan real quick in here?
Okay.
So you have data preprocessing augmentation as 2 weeks. I might stretch that out just in case if I was you, because the TCIA data set might be like in a pretty nice form, but you don't really know how the Fiona Stanley data is sort of going to come your way. So you may need a little bit more time to pre-process that so that it's in the same format as your training data as well.
Okay, I will.
I would also just recommend that for data augmentation, if you go back to slide 7, as you can see for NNUNet, it already does actually a bunch of data augmentation during its cross-validation for you. I'm not too familiar with the SWIN transformer, so you may not need to devote time and energy to data augmentation if it's already being implemented by the architectures you're using. So I'll just double check that also for whichever source you use to implement the SWIN transformer.
Yeah.
Anyway, thanks, Yunhe.
Okay, thank you.
Thanks, Nathaniel. I'm going to jump in with a question of my own. So Yunhe, we heard a bit about segmentations and how you plan to compare them to the manual delineations and things like that. But of course, segmentations are really only a means to an end. One thing we didn't hear much about is what sort of features you've determined from the literature are already associated with these outcomes that we're interested in predicting. So lymphoma patients undergoing CAR T cell therapy, which features from these FDG PET scans are already known or thought to be associated with overall survival and these catastrophic neurotoxicities that we're interested in predicting in advance?
I think it's the metabolic parameter of the maximum standardized uptake values, the TLG and the metabolic tumor volume. I think those features we'll get from the PET CT scans.
So those are features you've identified from the literature that are thought to be associated with these outcomes?
Yeah.
Okay. Do you think there's scope to expand this to perhaps more complicated features than these ones that you see here, which are relatively simple and easy to extract from PET images, say to something like a radiomics analysis that could potentially even go to the lesion level rather than the patient level, like the features that you can see there?
Yeah, I will look into that. Yeah, in the future.
Thanks, Yunhe. Yihang, jump in with a quick question, and then we're going to have to call it there, I think.
I'm just following up a bit about what Mubashir has said about are you doing some pre-training or not? For the SWIN UNET transformer, I think the paper that proposed it actually did some self-supervised learning in at the beginning. So it would be good if you could just use their train parameters. Now, one thing you need to think about is because you are doing the segmentation on a PET CT scan. So I haven't done segmentation on PET CT, so I'm not sure. Is this, when you're doing the segmentation, how many image channel you're having? Because usually RGB is 3 channel, but for medical image, usually that's just gray level, so it's just 1 channel. If we want to use the pre-trained weights on RGB, you can just expand that single channel to 3 channel. But then for PET CT, you have a CT channel and you have a PET channel. This is my understanding. So is that 2 channel thing? Or anyway, you need to find out a method so that the pre-trained weights, whether it's from other CT scans or is it from like natural images, can be used for you. I think this is a very important thing you need to keep in mind.
Okay, I'll keep in mind with that. So the RGB channel and the CT channel, is that 4 channel in total? Because the CT channel is a grayscale.
Usually RGB is just like natural images, CAD stocks. These are RGB, so it's 3 channel. CT usually it is 1 single channel. You just duplicate the gray level channel twice, so you make it to be a 3 channel thing, so that you can use the weights trained on RGB images. But maybe I don't know if Jake knows this. Like when you are doing the segmentation, how many channels you are using there?
Yeah, so with a PET CT image, you typically just use the 2 channels. So one would be the PET image, and one will be the co-registered CT image in the same coordinate spacing. So that's probably what Yunhe would end up doing.
Right. Okay. So for the transformer, you might want to figure out a way to utilize the weights by other people, or you might want to do some self supervised training yourself. But this is something to figure out in the next few months. So yeah.
Okay. Thank you for
yeah. Thanks, Yunhe.
Great presentation.
Yeah, that's a really good point. Yeah.
Yeah.
Right. Excellent. We'll call it there. So thanks, Yunhe, for the presentation. I'll just stop the recording.